Good evening, good afternoon. I would like to thank the organizers for inviting me to present in this pressure source webinar. I will present classification and dressings. I have no potential conflict of interest to report. And I will start with a new classification. In collaboration with its international partner, the European Pressure Ulcer Advisory Panel, a recommendation was made to change the word stage or grade to category to convey no directionality. Many European countries have replaced stage or grade with category to avoid this misinterpretation. The United States chose to stay with the term stage. However, this was done with a clear understanding that stage should not imply progression or reverse staging. Category or stage 1 of pressure injury, the non-blanchable erythema of intact skin, which may appear differently in darkly pigmented skin. We have the presence of blanchable erythema or changes in sensation, temperature, or firmness may precede visual changes. Color changes do not include purple or maroon discoloration. This may indicate deep tissue pressure injury. Category or stage 2, a partial thickness skin loss with exposed dermis. The wound bed is viable, pink or red, moist, and may also present as an intact or ruptured serum-filled blister. Adipose is not visible and deeper tissues are not visible. Granulation tissue, slough, and eschar are not present. Category or stage 3, a full-thickness skin loss in which adipose is visible in the ulcer, a granulation tissue and epibole, the rolled wound edges, are often present. Slough and/or eschar may be visible. The depth of tissue damage varies by anatomical location. Areas of significant adiposity can develop deep wounds. Undermining and tunneling may occur. Fascia, muscle, tendon, ligament, cartilage, and/or bone are not exposed. In category or stage 4, a full-thickness skin and tissue loss with exposed or directly palpable fascia, muscle, tendon, ligament, cartilage, or bone in the ulcer. Slough and/or eschar may be visible. Epibole, undermining and/or tunneling often occur. The unstageable pressure injury, a obscured full-thickness skin and tissue loss in which the extent of tissue damage within the ulcer cannot be confirmed because it is obscured by slough or eschar. If slough or eschar is removed, a stage 3 or stage 4 pressure injury will be revealed. The deep tissue pressure injury, a persistent, non-blanchable deep red, maroon, or purple discoloration, intact or non-intact skin with localized area of persistent non-blanchable deep red, maroon, purple discoloration, or epidermal separation revealing a dark wound bed or blood-filled blister. Pain and temperature change often precede skin color changes. Discoloration may appear differently in darkly pigmented skin. We must not use DTPI to describe vascular, traumatic, neuropathic, or dermatologic conditions. Some discussion about the new classification. The change in terminology describes more accurately pressure injuries to both intact and ulcerated skin. In the previous staging system, stage 1 and deep tissue injury described injured intact skin, while the other stages described open ulcers. This led to confusion because the definition for each of the stages referred to the injuries as pressure ulcers. In addition to the change in terminology, Arabic numbers are now used in the names of the stages instead of Roman numerals. The term suspected has been removed from the deep tissue injury diagnostic label. Additional pressure injury definitions agreed upon at the meeting included medical device-related pressure injury and mucosal membrane pressure injury. When classifying injuries caused by pressure and/or shear, the clinician has the following options. 1. If the type of tissue in the wound base can be evaluated, numerically classify as stage 1 or 2 or 3 or 4 based on the deepest tissue type exposed. If the wound base cannot be evaluated, classify it as A. Deep tissue pressure injury when the skin is intact with deep red, purple, or maroon discoloration or blood blister, and B. Unstageable when the base is obscured with slough or a scar. And third, if on a mucosal membrane, document but do not stage. The importance of moist wound healing is here presented. For the best wound care outcome and the quickest healing process, moist wound healing is the best choice. Today's wound care dressings have moisture management properties to fulfill all of the function of the passive dressings of earlier times, but also promote faster healing, reduce pain, encourage vapor transmission, promote autolytic debridement, and also act as a bacterial barrier. The benefits of moist wound healing are as follows. Wound healing takes less time. Keratinocyte cells function more easily. Autolytic debridement is facilitated, decreases incidence of wound infection, preserves growth factors in wound fluid, stimulates collagen synthesis, reduces pain and reduces scarring. Now some slides about the dressing classification based on exudate level, presence of infection, bacteria, and pain for stages 2 to 4 and not infected wounds. And please note that in case of necrotic tissue, slough and or scar should be removed with surgical debridement prior to dressing selection. We have various foam dressings. Foam indicated for the treatment of moderately to heavily exuding wounds. A silicone foam indicated for the treatment of low to heavily exuding wounds with fragile periwound skin, and foam with ibu, foam dressing containing ibuprofen for the treatment of moderately to heavily exuding painful wounds, and provides sustained release of a low dose of ibuprofen into the wound bed throughout the wear time of the dressing. We have alginate hydrofiber dressings, indicated for the treatment of moderately to heavily exuding pressure ulcers with cavity, and hydrocapillary dressings, indicated for the treatment of low, medium, and highly exuding wounds. For stages 2 to 4 and infected wounds with delayed healing due to bacteria or wounds at risk of infection, and in case of wound bed discovered with slough, yellow, tan, gray, green or brown, and or a scar, tan, brown or black in the wound bed, category stage cannot be determined. Following surgical debridement, the damage may be assessed in order to select appropriate dressing. We have silver foam dressings. In the presence of exudate, silver is continuously released into the wound bed, providing antibacterial effect during the entire wear time. Silver foam is indicated for the treatment of moderately to heavily exuding wounds with infection or with delayed healing due to bacteria or wounds at risk of infection. And silver foam with silicone is indicated for the treatment of moderate to heavily exuding wounds with infection or with delayed healing due to bacteria or wounds at risk of infection. Silicone silver foam dressings are preferred in cases of fragile periwound skin. Alginate dressings with silver are indicated for the treatment of moderate to heavily exuding wounds with cavity and infection or with delayed healing due to bacterial wounds at risk of infection. And wound contact layers with hydrocolloid and silver sulfadiazine are indicated for the treatment of low to moderate partial thickness, burns, and acute wounds in need of antibacterial protection. And finally, dress classification for stage 1, not infected wounds, hydrocolloid dressing, as you see in this picture. And for unstageable depth unknown stage, the wound bed discovered by slough and or a scar, until enough slough and or a scar is removed to expose the base of the wound, the true depth, and therefore the category or the stage cannot be determined. Following surgical debridement, the damage may be assessed in order to select the appropriate dressing, and hydrogels here. usually contain high amount of water. They are used for wounds that need effective and gentle debridement on necrotic tissue. I would like to thank you for your attention and your invitation.